Whether this is your first or your 25th Doctors for Global Health General Assembly, bienvenidos. I draw your attention to the fine print at the top of this page. We are here to talk about liberation medicine, 25 years of action, reflection, and living theory. I'm thrilled that you all are here to share this ethereal space. The ancient Greeks believed that the earth was composed of earth, air, fire, and water, but that the heavens and its denizens were made of a purer, less tangible substance known as ether, or quintessence. Ether was often described as an invisible light or fire, and its name derives from the Greek athein, a verb meaning to ignite or to blaze. Apropos for this time. My hope is, after spending this time learning and reflecting, each one of us is inspired, compelled, driven to ignite new ideas and new ways of being with one another. And if the blazes lead to ashes, to rise from them, renewed and empowered, to continue to say yes to, and I quote, everything which is natural, which is infinite, which is yes, in the words of E.E. Cummings. And to bring us back to earth, to do the daily work, feet in the soil, hands in the dirt, to work for equity. My name is Dr. Jennifer Casper, and I've been a member of Doctors for Global Health since 2006, when it wasn't even yet Doctors for Global Health. I was invited to speak about liberation medicine, the conscious and conscientious use of health to promote human dignity and social justice, a term that we at Doctors for Global Health created and use. Let's unpack this definition. Conscious, to be awake, to act with critical awareness. Conscientious, meticulous, careful, scrupulous, having moral integrity. Human dignity, the recognition that human beings possess a special value intrinsic to their humanity, and as such are worthy of respect simply because they are human beings. In the words of Dr. Jack Geiger, the founder of the Community Health Center movement, all lives are worthy of life. Social justice, the fair and just relations between the individual and society. It includes a duty of the state to distribute certain vital means, such as economic, social, and cultural rights, the protection of human dignity, and affirmative actions to promote equal opportunities for everybody. Liberation medicine is the conscious, conscientious use of health to promote human dignity and social justice. While liberation medicine within Doctors for Global Health is not aligned with any particular religion, its ideological roots are found in Christian liberation theology. Liberation theology, as a theological construct, emerged from within the Catholic Church after the Second Vatican Council in 1968. This Vatican Council, under the leadership of Pope John XXIII, reaffirmed that the Church should focus on service rather than power. Acts of solidarity with the poor and the oppressed in their fight for justice were deemed the most fitting ways for the Church to react to its mission. Liberation theology has its origins in Latin America. In the mid-1950s, as socioeconomic development pushed the peasant workers and farming populations into desperate poverty. With the economic unrest came political unrest, and military dictators took over many governments in the name of national security. DGH has accompanied and continues to accompany many countries in Latin America. Liberation theology is based on a preferential option for the poor and oppressed. Poverty is an affront to human dignity, and therefore solidarity with the poor should be the main mission for those serving what they know to be their spiritual power. Out of this arises one of the cornerstones of liberation theology, namely the concept of praxis. Simply defined, praxis is action informed by ideology. According to Gustavo Gutierrez, one of the most well-known and well-respected liberation theologians, liberation theology reflects on a practice of solidarity in the interest of liberation. Because of this preference for the poor, liberation theology often calls for reorganization of social, governmental, and economic structures so that the poor are not merely cared for, but brought into the fullness of human flourishing. In the realm of public health and medicine, this praxis arises from radical philosophies, secular documents such as the Universal Declaration of Human Rights, and the words and deeds of people and communities whose lives are spent fighting oppressive power structures. Gustavo Gutierrez contrasts the concepts of liberation and development. Development has acquired a negative connotation because it usually implies a connection to groups that are closely tied to organizations and governments that control the world economy. Historically, therefore, many development initiatives have posed no real threat to the status quo and have ensured that the interests of those organizations and governments in power are safeguarded. This is usually done at the expense of true sustainable development initiatives that seek to benefit the poor by significantly raising their quality of life. As a result, poorer countries are realizing that the only way true development can come about is to break their ties with the dominant organizations and governments, and thus liberate themselves to be engines of their own change. This is change arising from the grassroots. As people showing a preferential option for the poor, our role in Doctors for Global Health is that of accompagner, rather than administrator. We are called to dismantle power structures and work in the interest of human liberation, rather than cost-effectiveness or some other metric created by those in power, which often shortchanges the poor. Liberation medicine is a channel of radical change through which true development can come about. Liberation frees poor countries from the detrimental influence that dominant global power structures, such as the World Bank, the International Monetary Fund, and the G7 group of nations have on most sustainable development initiatives. Gutierrez describes liberation as a permanent cultural revolution, whose historical consequences are ongoing. Liberation allows the poor to decide for themselves what they need and empowers them to explore different ways of achieving their goals. Once the poor are empowered, true development and liberation for health and healing can occur. I mentioned our role at DGH is accompagner. We have adopted accompaniment from other grassroots organizations. It connotes a specific perspective, a paradigm of how to work with marginalized populations. It implies being invited rather than arriving without prior community knowledge or approval. It implies a participatory process with the community rather than imposing our way of thinking or doing things on or to the community. I've unpacked the definition of liberation medicine and explored its roots. Now I would like to examine how it is applicable today. We live in a time of social injustice. We have far too many examples of the poor, oppressed, and marginalized, people who are treated as less than human, deprived of their dignity. The ills of society are embodied in them. To quote Nancy Shepherd-Hughes and Margaret Locke, sickness is not just an isolated event, nor an unfortunate brush with nature. The individual body should be seen as the most immediate, the most proximate terrain where social truths and social contradictions are played out, as well as a locus of personal and social resistance, creativity, and struggle. I will now describe how liberation medicine is relevant today to our triple pandemic: coronavirus, racism, and misinformation. As of 3 p.m. today, there were 16.6 million total confirmed cases of coronavirus, 66,500 of whom were in critical condition, 657,000 of whom deceased. There is a total active caseload of 5.8 million, and slightly over 10 million have recovered fully. But we know this is not the whole story. Author Keeanga Yamata Taylor called COVID-19 the Black Plague in her recent New Yorker article. Public health officials lament the way coronavirus 19 is engulfing Black communities, but what are they prepared to do about it? She asks. So who are the most vulnerable? Who are the most affected in this pandemic? Who should we show a preferential option for? I will focus on people who are essential workers, people experiencing housing instability and the threat of eviction, people who are homeless, people who are incarcerated, people who are immigrants or living in immigrant families, and children. I will also briefly examine COVID-19 from a global perspective. One way to find out who is most vulnerable and most affected is to apply the work of Dr. Kamara Jones. In any public health crisis, we need to ask ourselves, how is racism, classism, nativism, sexism, etc. operating here? We need to identify mechanisms, the structures, the who, what, why, when, and where of decision-making, the policies, the written how, practices and norms, the unwritten how, and values, the why. For those who wish to explore the issue of racism and pandemics, there is a very good short video from The Root. From unskilled to essential, workers are vulnerable. When we are ill, we are told that it's you who will heal us. When we come to you, our rags are torn off us, and you listen all over our naked body. As to the cause of our illness, one glance at our rags would tell you more. It is the same cause that wears out our bodies and our clothes. Numerous people working in our meatpacking plants across the United States have been affected by COVID. In fact, greater than 150 of America's largest meat processing plants operate in counties where the rate of coronavirus infection is already among the nation's highest. These facilities represent more than 1 in 3 of the nation's biggest beef, pork, and poultry processing plants. Rates of infection around these plants are higher than those of 75% of other U.S. counties. Meat and poultry employees have among the highest illness rates of all manufacturing employees and are less likely to report injuries and illness than any other type of worker. But rather than increase safety and oversight, the U.S. Department of Agriculture relaxed it. As an example, the agency allowed 15 poultry plants to exceed federal limits on how many birds workers can process in a minute. The CDC guidelines are not enforceable in meatpacking plants. A bill introduced in the U.S. House of Representatives would require OSHA to issue enforceable safety standards to protect workers. There are a number of things that put these workers at more and greater risk. For one, they have no paid sick leave. And for two, in many cases, they cannot afford insurance, and so they go through without it. Another vulnerable group are the individuals, families, and households facing housing instability and evictions. By many estimates, homeownership is the most reliable wealth-building vehicle the American economic factory has ever produced. Home equity allows people to get money when they need it, which delivers them from many financial perils. It can also help them accrue wealth and pass it along. In the first quarter of 2020, 74% of white people own their homes, whereas only 44% of black people did. This is due in part to historical racism and discriminatory practices over the years that limited black people's access to homes in certain areas and to mortgages, especially those at attractive interest rates. This disparity in ownership is one of the reasons that, in 2016, the median black household income was $13,000, while the median white household income was $149,000. A study by Children's Health Watch published in Pediatrics in 2018 found that among 25,000 families, 1/3 had housing-related challenges. 1/4 were behind on rent payments, 10% had undergone multiple moves, and 12% were homeless. In their study, housing instability was associated with child and mothers in poor and fair health, maternal depression, food insecurity, and healthcare trade-offs. Those of us who live in Massachusetts are lucky that an eviction moratorium is in place through the end of the year. But at the federal level, the moratorium is scheduled to end at the end of July. Some Democrats have called for a $100 billion national rental assistance program. And Senator Kamala Harris, Democrat from California, has unveiled a sweeping housing plan that would ban evictions and foreclosures for a year, while giving tenants up to 18 months to pay back missed payments. But neither idea has gained traction with Senate Republicans. Another group who is vulnerable are people who are homeless. One Columbia University analysis of unemployment figures suggested that by the end of 2020, homelessness would increase by 40%. The Aspen Institute estimates that by October, 1 in 5 American renters could face eviction. One study in Massachusetts found that of 397 homeless individuals living in the Pine Street Inn, 146 were found to be COVID positive. That is an infection rate of 33%. We have much to do to address the issue of COVID-19 and other health concerns among people who are homeless. Another vulnerable group are people who are incarcerated. According to Rachel Bedard, a geriatrician at Rikers Island, which has positive cases of coronavirus, a prison is a perfect environment for an outbreak. There are currently 2 million people in prisons and jails, and people who are incarcerated are more likely to have serious mental illness, chronic illness, substance use disorders, and are aging at a faster rate than the general population. Also, 1.5 million children in the United States have parents who are incarcerated. Rikers Island is a mini-city unto itself. It is not just detainees and guards. It is thousands of people coming in and out every day. And so, in the same way that a city like New York would struggle with the complexity of its response to COVID, Rikers is doing that on a smaller but almost more urgent scale because, like a nursing home, a jail is a perfect setup for an outbreak. Immigrants are vulnerable. They're vulnerable because prior to COVID, they were denied many public assistance programs, such as Medicaid, the Supplemental Nutrition Assistance Program, and subsidized housing. And now at a time when many immigrant families need assistance because they are disproportionately experiencing economic hardship and health risks from COVID-19, the duly implemented public charge rule threatens to further dampen their participation. In addition, the United States operates the world's largest immigrant detention center and system. On any given day, the country has approximately 30,000 people in administrative immigration detention. Texas, Louisiana, Georgia, Arizona, and California have the largest immigration detention centers. And 70% of immigrants in detention are in private detention centers that have little to no oversight. Immigrant families are being disproportionately affected by the economic turmoil brought on by the pandemic. But so far, the supports included in the federal stimulation legislation, including the economic impact payments and expanded unemployment insurance benefits, are not available to all immigrant families. Additionally, the U.S. Supreme Court has rejected requests to suspend implementation of the public charge rule during the COVID pandemic. Another vulnerable group are children, and I will use the example of children in the Boston Public School. The Boston Public School system serves 53,000 students, including 4,500 who are homeless. More than 70% of the student population is economically disadvantaged, and BPS serves approximately 50,000 free meals to students every day, including breakfast, lunch, and after-school meals. So, school closures have a detrimental effect on not only the health and well-being of children, but on their nutritional status as well, which also has health and well-being implications. Now let's take a look at the global COVID-19 pandemic. We know that there are few areas in this world where people have not been affected by COVID. What we must keep in mind is some countries have only a few dollars per person to spend on healthcare. 57 countries have severe human resource constraints, and many countries have no intensive care unit capacity, no ventilators, no personal protective equipment. The people in the masks in this slide are Etovina, a community health worker, and Samuel, the local physician in Estancia, El Salvador. I'd like to take a moment to focus on the issue of food insecurity. Let's take a moment to understand these images. In the upper left, you can see the numbers of acutely food insecure people in crisis or worse. And they include 77 million in 22 countries experiencing conflict or insecurity, 34 million in 25 countries experiencing severe weather conditions, and 24 million in 8 countries that are experiencing economic shocks. The map on the right shows you where the greatest numbers of food insecure people are currently living. And finally, the graph on the bottom shows you the origins and primary regions of the diversity of agricultural products. Globally, the top global producers of food are China, India, the US, and Brazil. And 2 of those 4 places lead the world in coronavirus infections. The Committee on World Food Systems, a high-level panel of experts on food security and nutrition, explained recently the crisis is already affecting food systems directly through impacts on food supply and demand, and indirectly, but just as importantly, through decreases in purchasing power, the capacity to produce and distribute food, and the intensification of care tasks, all of which will have differentiated impacts and will more strongly affect the poor and vulnerable. Since the outbreak, 11 countries have erected food export bans. And for a place like the Caribbean, they source up to 94% of their food from the US market. So, high rates of infection amongst our meatpacking plants and the like have huge ramifications for the health and well-being of the Caribbean community. For those who would like to learn more about the impact of COVID-19 on the human right to food and nutrition, I refer you to this paper. Using a liberation medicine lens requires this sophisticated, conscious, and conscientious analysis of our triple pandemic: coronavirus, racism, and misinformation. As I stated earlier, the cornerstone of liberation theology and liberation medicine is praxis. There is no better example of this than the Black Lives Matter movement. I encourage you to read DGH's statement on COVID-19 found on our website. We recommend action to continue speaking the truth about the current COVID-19 pandemic that has aggravated biases, racism, and health disparities. This weekend, you will learn about the praxis of liberation medicine in our Doctors for Global Health partner communities in El Salvador, Mexico, and Uganda. You will also hear from the Social Medicine Consortium and their campaign against racism. You will hear from Shamshir Samra about his prison justice work in Los Angeles, California. You will hear from Anjali Taneja, Cara Page, and Susan Raffel about their work with Casa de Salud in Healing Histories, Disrupting the Medical Industrial Complex. Praxis is local, national, and global. I encourage you to share with us and others what praxis looks like to you. In the daily course of our lives, we get distracted and veer off course. And there are people spending and making millions and billions of dollars to distract us and keep us distracted so that we lose sight of our true north. This weekend is an opportunity to adjust our compasses. We are a group of people from many walks of life from around the world. You are people of hope, creativity, commitment, and activism, or you wouldn't be here. It is an honor to share this space with you. This 25th anniversary Doctors for Global Health General Assembly will be thought-provoking, challenging, and inspiring. My hope is that we walk away from this assembly with a renewed vision of finding, clarifying, and following our true north, one that is based on liberation medicine, the conscious and conscientious use of health to promote human dignity and social justice.